is Eric Goldwine. I am LTCC's Policy and Communications Director. And just a little bit about LTCC. If you could go to the next slide, we are a nonprofit, nonpartisan organization dedicated to improving care and quality of life for elderly and adult disabled in long-term care. We focus on policy research and analysis, systems advocacy, public education, and we are also home to 2 local long-term care ombudsman programs in New York State. Now, why are we here today? We have a webinar on nursing home staffing, competency, and care, understanding staffing, training, and responsibility requirements. And leading this program will be LTCC's Executive Director, Richard Mollett, and he'll discuss what families, advocates, ombudsmen, and everybody should know about nursing home staffing competency requirements. And again, materials including slides, video, and a fact sheet will be available on nursinghomes411.org/webinar-staff-competency. And I'm going to hand it off to you, Richard.
Great. Thanks so much, Eric, and welcome everybody. I think Eric gave us this information. Hold on one second. There we go. So a little bit about why we're doing today's program. We're actually putting together 2 reports on staffing. One is a survey of all of the state certification requirements for certified nurse aides. And the other is a white paper to support better staffing in our nursing homes, both of which should be out, I'd say by the beginning, hopefully by the beginning of February. But as I was reviewing the report, on CNA training requirements and looking at the federal requirements, it occurred to me that there's so much there that we don't always think about and we don't always realize and that are really important. And we always talk about in our advocacy, and we often hear about how, there's insufficient staffing and so many nursing homes don't have enough staff just to meet residents' basic needs. But it's also critically important that those staff have the competencies, the knowledge, the skills to meet their residents' needs. If they don't have, if they're not equipped with that knowledge and those skills, then residents suffer and the care staff themselves suffer because they're not able to do the job that they were hired for and that they want to do. In addition, I thought that, one reason for doing today's program is that equipping people who work with nursing home residents or who are residents themselves, family members, policymakers, with the knowledge of what we can expect of nursing home staff would be really valuable. And that is a way of supporting our advocacy. It's a way of supporting and understanding what we have a right to expect of nursing homes and of the staff that they hire and that they train. So I'm going to, here's a breakup of what the discussion will be. I'm going to start with a brief background on the nursing home system and on federal requirements. And I quite often do that just to provide a basis for what we're talking about, why it exists, and why it is important. And then we're going to talk about some of the general competency requirements for nursing home staff. And then the bulk of the discussion will be about training and competency requirements, in particular for certified nurse aides. Then I just, when we go from there towards the end, I want to talk about some of the myths that nursing homes are using to say that they can't hire and maintain sufficient and competent staff. This is always what we come up against, is that nursing homes say, well, we don't get enough money, well, the staff aren't out there, et cetera. And in fact, those are not based in reality. They are more talking points for a very highly paid and very wealthy industry. So we want to provide some support for implementing these standards, implementing these skills in the lives of residents. And how do we do that? How do we support your advocacy by, I think, dispelling some of those myths? And then we'll end with some of the resources that we have on our website, as well as, of course, time for Q&A. We're going to have question and answers at the end, please. So Please, as Eric said, if you have any questions, put them in the Q&A. The chat, excuse me, is for any comments you're welcome to share and chat about. But if you have a question please save it for the end and please put it in the Q&A. So, as I said, I'm going to start with a brief background on the federal requirements. Just a couple of things before I get started here is that one, everything we're talking about today relates to nursing homes. It does not necessarily relate to adult homes, assisted living, other residential care settings. And in addition, everything that we're going to talk about today pretty much relates to the federal requirements. As I said, we're coming out with a report, hopefully in the next few weeks, on what the individual state requirements are. State requirements, as I'll note later on, are in addition to any federal requirements. That's true for basic nursing home standards, and it's also true for CNA, certified nurse aid training standards as well. The states can have more, but we typically here at LTCC talk about the federal requirements because that's really the basis for all care in licensed nursing homes across the country. It's important, as I note here in the last slide, that when we say nursing home is licensed under Medicare or Medicaid, it participates in Medicare or Medicaid. There's different ways of putting it, but that is entirely voluntary. So as I mentioned before, when a nursing home says, oh, we're not getting enough money, Medicaid doesn't pay for that, Medicare doesn't pay for that, etc. Nursing homes that do not wish to participate in Medicare or Medicaid do not have to. It's not obligatory. There are private nursing homes out there. There are not a lot of them. Why aren't there a lot of them? Because there is, in fact, a lot of money in the Medicare and Medicaid system, and the government pays through Medicare and Medicaid, one, as I said, a lot of money to facilities, but also it's a very steady source of income. So nursing homes voluntarily do this because that is where the money is, no matter what they say. Lastly, before I move on, is that, as I know at the top, the law passed in 1987. So nothing that we talk about is new. These things have been in existence for 87, 97, 2007, 40 years or so, 35 or so years, excuse me. So this is nothing new. It's not the first Sunday that this is happening. It's not the first year and they're gearing up. These are things that nursing homes should know and be aware of and be in compliance with for many, many decades. A little bit about the nursing home reform law, and I know those of you who have participated in programs that I've done have probably seen this before, but it's really important to me in my work, and I want to convey it as well to you, is that the federal requirements for nursing homes under Medicare and Medicaid, you take any amounts of Medicare and Medicaid money, is that you have to provide to every single resident that you accept in the facility the appropriate care and quality of life services that they need on an individual basis to attain and maintain their highest practicable physical, emotional, and psychosocial well-being. That's not highest practical, and it's highest practicable. Highest practical would mean, well, this is how much I want to spend on staffing and on food, so this is what you're getting, that's what's left over. No, it's highest practicable based upon the resident, their individualized resident-centered care plan, their assessment, which is what that care plan is based on, et cetera. It's really the law requires a focus on the resident as the nexus of care. So the question, and I pose this quite often to myself and in our programs, is if the law and the standards are so strong, are so resident-centered, why aren't nursing homes better places to live and to work? Why is so much care we receive kind of cookie cutter and oftentimes very poor? And the answer to that is that the laws and the standards can only make a difference in the lives of residents, and I would say care staff too, if they are enforced. These laws just because they exist doesn't mean that it happens in the lives of residents. And I know that is a source of frustration for residents and families and ombudsmen, attorneys, and the people who we work with in policymakers of both the state and the federal level. Well, what laws do we need? Well, the laws are good. They just need to be enforced. We'll talk about that a little bit here. As I note here, this is just a bunch of different reports, federal reports, our reports, reports from news media, et cetera, is that too often the basic standards of care for residents are not met. This is just a quote from the New York Times this is why nursing homes failed so badly in relation to the COVID pandemic from December 31st, 2020. Long-term care continues to be understaffed, poorly regulated, and vulnerable to predation by for-profit conglomerates and private equity firms. And in our words, the fundamental problem is that in the absence, again, of meaningful enforcement, the nursing home operators can largely provide any level of staffing they want and any quality of care and quality of life services that they choose. Again, getting back to that, what I said before is that they operate highest practical. This is what we're going to do based upon how much money we want to pull out in profits or in overage or administrative costs, et cetera. And that's what's left over. But no, that's not what the reform law requires. But again, in the absence of enforcement, this is what happens too often. So what can we do about it? And this is, a question I often get from when I first started doing programs early in my career, is that people would come up to me afterwards and say, well, what are we supposed to do? The rules themselves, don't make a difference in my loved one's life, talking about a loved one in a nursing home. And from our perspective, and we've seen this in practice, is that knowledge of requirements for nursing home care, including, as we're going to talk about today, those for care staff and for the provision of services, can support effective advocacy for resident safety and dignity, both at the individual level, individual facility level, individual resident level, but also I think at the systemic level. If you know what you're entitled to, then you have a basis for which to advocate for better care and raise expectations. So I'm going to talk about some of the basic requirements for nursing services. In the nursing home world, again, this only applies to nursing homes, does not apply to assisted living. There are essentially three categories of caregivers. There are registered nurses, there are licensed practical nurses, also known in some states as licensed vocational nurses, and then there are certified nurse aides. Those are the three types of people who provide care in the nursing home, most care in the nursing home environment. You rarely see a doctor. Some nursing homes now have nurse practitioners, et cetera, and that's great. They mostly provide oversight. Really, the people who are providing bedside care, for the most part, are the CNAs, and then providing supervision, providing some other services. On top of that are the LPNs, LVNs, and the RNs. So this is exactly directly from the federal requirements. The facility must provide services by sufficient numbers of each of the following types of personnel on a 24-hour basis to provide nursing care to every resident in accordance with the resident care plans. Licensed nurses, that means the RNs and the LPNs or LVNs, and nurse aides. Now, as I note here in the last bullet in the orange box, facilities may also use feeding assistants. We don't have time to get into feeding assistants, but essentially, several years ago, the federal government, as a result of industry pressure, allowed nursing homes to hire feeding assistants with very, very little training. They, in essence, allowed states to permit the nursing homes in their states to use feeding assistants. Those are not considered nursing staff. And for a variety of reasons, both for the well-being of care staff as well as for the well-being of residents, we and other advocates strongly objected to the imposition of this rule allowing feeding assistants many years ago, and do not support it at all currently. So a little bit more about nursing services. And as a note here, as I did in the last slide as well, 42 CFR, that's the citation to the Code of Federal Regulations. The reason why we often include that, and we include it in pretty much, I think, all of our fact sheets, is again, for you to have a reference to the federal requirements or the rules or the guidance regarding what we're talking about. So it's not just my opinion. It's not something I'm saying to you here because I think it's a good idea. These are actually the federal minimum requirements. That F number, as some of you I'm sure know, that refers to an F tag, and that is what is used by the surveyors, the inspectors, when they cite a facility for a certain deficiency. It has an accompanying F tag. The reason why we include it here, and again, you'll see it in our fact sheets, and what I talk about here comes from our fact sheet, so you could find it on our website after this program, is if your facility is cited, say after its annual inspection or after a complaint investigation, those citations are available at the nursing home. They're available on the federal website, medicare.gov, and they are available, and every state is required to have a nursing home website to which they post these, what they're called statements of deficiencies. With every statement of deficiency, where there's a deficiency, there'll be an F tag. So we want you to be able to make that connection. Hey, if my facility was cited for F725, you can come back to our website and you could see what F725 was, what they were supposed to be doing, and what they were found not to be doing. And that can help with families, it can help with residents, resident and family councils, ombudsmen, others who are advising residents and families, help them to understand what the problem was, what the expectations are, and what the facility should be doing to correct any problems that were identified. So here, as I digressed, nursing services, this is really important. The facility must have sufficient nursing staff with the appropriate competencies and skill sets, to provide nursing and related services to assure resident safety. And again, those words, attain or maintain the highest practicable physical, mental, and psychosocial well-being of each resident, as determined by the resident's assessment and individual plans of care, pardon me, and considering the number, acuity, and diagnoses of the facility's resident population in accordance with the facility assessment. So there's a whole lot here. And again, a strong foundation in the rules that we're talking about, not just sufficient number of nurses, we're talking about appropriate competencies and skills, and that those match up with the needs, the goals, et cetera, of the residents, not just their clinical needs, their mental and their psychosocial needs as well, and requiring, if you see towards the end here, that this is based upon the individual assessments and care planning of the residents, as well as what the facility is doing in its own assessment. What is going on in our facility? The facility has a responsibility to identify any problems that are going on, whether it be through being told by staff, being told by residents or families, or resident or family councils, through receiving a grievance from someone in their community, or again, through a citation. All those things are supposed to be used on an ongoing basis by nursing homes as part of their ongoing quality assessment and performance improvement planning to identify what is going on and how do we fix it. Why? Because surveyors are only there once a year or so, and they're only there for a few days. It's up to the facility. It's expected of the facility that it is going to be doing quality control on an ongoing basis through these various mechanisms. Just as a quick aside, I know that these are big challenges, and that's why I said, earlier, hopefully with the knowledge and hopefully knowing that the knowledge and the expectations about standards is connected and through fact sheets, et cetera, to what you are doing and to what you are seeing, hopefully that will provide a strong basis for advocacy. I have been a family member of a nursing home resident many times in my life. I know how frustrating and difficult it can be to address some of these challenges. But again, with our knowledge of our rights and our residents' rights, we can help use that as a basis to turn the tide and to make things better. So I'm going to spend some time, really the bulk of our program, talking about the training and competency requirements for certified nurse aides and things for you to think about in that regard. So this is a summary. Again, everything I talk about is regarding the federal requirements, but as I note here, and we're coming out with a report, as I mentioned, on the states can have stronger requirements for training. And this is really important. We want to make sure that the CNAs, as the earlier slide said, are equipped to provide the care and the services that each resident needs. So the minimum federal requirements, the third bullet, excuse me, as you can see with the orange arrows, all nurse aid certification training programs must provide, quote, no less than 75 clock hours of training, unquote, including at least 16 hours of supervised practical training. This is for the certified nurse aides. Practical training means, quote, training in a laboratory or other setting in which the trainee demonstrates knowledge while performing tasks on an individual under the, unquote, under the appropriate supervision. And then I'll talk about some of the skills and subjects that must be covered. Before I move on, though, I just want to mention the CNAs, as I'm sure many of you know, provide the vast majority of bedside direct resident care in nursing homes. So here are some of the federal CNA training requirements, and this I thought was really important. The federal regulations specify that before they have any direct resident contact, the individuals must complete at least 16 hours of training in communication and interpersonal skills, in infection control, in safety and emergency procedures, in promoting residents' independence, and in respecting residents' rights. And it's kind of here when I was reading this and reviewing our forthcoming report, I thought, you know what, I really want to do a program about this because there are so many of these things, like, of course, it's that I wasn't always thinking about. They have to be trained in this. They have to know this. And this is not criticizing CNAs who don't have the training, because most people want to do a good job. Not everybody, but most people do. And the problem is that the CNAs themselves are often not equipped here in these respects. So respecting residents' rights, safety, emergency procedures, infection control. How many infection control problems have we seen in our nursing homes, especially during the COVID pandemic, but on a day-to-day basis? Communication, interpersonal skills. How often do we see that lacking, especially when it comes to residents with dementia, which is a significant portion of the nursing home resident population? So again, before they have any direct patient contact, they have to have training in these 5 topic areas. To me, this was just really so interesting and important. And then here are some of the topics of the CNA training requirements. The curriculum must cover, each of these topics, and they include basic nursing skills, and that includes recognizing abnormal changes in a resident's bodily functions and how important it is to report any changes to a supervisor. Personal care skills, and we hear about this, we talk about this with the Family Council, which I'd like to say, hope to say friends with, and we've gotten to know. We talk about mouth care and grooming and skincare. Of course we do, because these are important issues. Mental health and social service needs, care of cognitively impaired residents. As I said before, most residents have some level of cognitive impairment in a nursing home, but we too often see a disconnect between their care staff and how the care staff are treating or relating to residents with cognitive impairment. So what is happening with that training? What is going on? Basic restorative services, including proper turning and positioning in a bed or a chair, very important for avoiding or reducing pressure ulcers. And then again, residents' rights. CMS talks about this all the time. CMS, the Centers for Medicare and Medicaid Services, the federal agency. Residents' rights are critically important. And that includes regarding residents' possessions, but it's also dignity. It's also about making choices and resident autonomy. And we see these over and over again in the rules and the requirements for nursing homes. But here, we're seeing that CNAs are expected to be trained and to know about the working and meaningful knowledge of these issues. So this is our fact sheet that we just coming out with today, and it's all directly, well, pretty much all directly from the federal rules, and it talks about each one of the basic categories and what the federal requirements actually spell out for each one of those categories. And again, the curriculum of a nurse aid training program must include, not can include, not should include, not if you have enough time, put it in, must include all these things. So if I'm a family member or a resident or someone working, they're like, well, what is going on? If I'm seeing that staff are not, don't understand how to communicate with someone who is cognitively impaired or doesn't understand the behavior of someone who has dementia, my question is part of my question is, or part of my approach is, I think, well, what is going on? Are they receiving the training? Have they received the training that they need? Yes, obviously sufficient staff. It could be that there's not enough staff, but again, we need to have staff that have the training and have the skills to implement these in the lives of residents. So as I mentioned a couple of times, we are putting together a report. If you would like to get a alert when that report is out, please sign up at nursinghome411.org/join. There's no cost to do that, and you'll get alerts for that report and for our other materials on occasion. But the important point here is that many states now have recognized that even this training that we're talking about, and as you can see, the federal requirements are pretty robust. It's not enough. It's not really enough to equip CNAs to be adequately trained, have enough knowledge, have the skills, have the support within themselves to meet the needs of residents and have a good career, which is what we want. So I'm going to a couple of slides about, how is this expectation supposed to be implemented? Because again, we see that there are, unfortunately, care staff quite often does not have, or too often doesn't have the skills, doesn't have the ability to address what is going on with residents and to provide constructive engagement and services to them. So the general rule is, again, this is from the federal rules and the guidance, is that a facility must not use any individual working as a nurse aide for more than 4 months on a full-time basis, unless that individual is competent to provide nursing and nursing-related services, they've completed a training competency evaluation program approved by the state, or the individual has been deemed or determined competent based upon long-term experience and other federal requirements. Non-permanent employees. So we're talking about first about the CNA staff, but for non-permanent employees too, this is critical. A facility must not use on a temporary, per diem, leased, or any basis other than a permanent employee, any individual who does not meet the above requirements. So it is not okay to just say, oh, we're hiring temps or per diem people from an agency and they don't know those things. No, they have to know those things. And then just a quick, you can see here in the orange, light orange box, the CMS statement on competency, a quote, a measurable pattern of knowledge, skills, abilities, behaviors, and other characteristics that an individual needs to perform roles or occupational functions successfully. This comes directly from the CMS training for inspectors, for surveyors. And I included here because, again, all the things I talked about, all those requirements, all the curriculum, they're just out there floating in thin air and not meaningful. CMS, again, the federal government is expecting that these are part of the work role, part of the functioning of the CNA on the floor and with residents. Just a quick note on the COVID pandemic waivers. So early in the pandemic, CMS waived the CNA training requirements. They essentially, again, gave this to the states, just like states could have increased training. Here they waived the requirements, and they said that states could themselves waive the requirements or even have lower requirements than the 75 hours, as little as no requirements for someone to work in a CNA capacity. And they were called, and still are called, TNAs, nurse aides in training, but TNAs. Importantly, as I know here in the second bullet, CMS did not and has not waived any requirement regarding the skills, knowledge, or competencies of anyone who is in contact, who is working with, who is providing services to residents. So there's absolutely no legitimate excuse, even if a facility was using TNAs or is still using TNAs, that person has to be, anyone who's providing care to the resident has to be, have the skills and the knowledge and the competency that we have been talking about, and at least at that level. But we were been concerned from the very start that as residents were, extremely vulnerable during the pandemic, especially when families and visitors and even inspectors were not going into facilities, that if anything, from our perspective, the residents needed people with higher abilities, not lower abilities, and that this was a mistake. And I think, unfortunately, that bore out in how many residents died, how many residents were harmed, both directly from COVID and, of course, as a result of neglect that they suffered because families and loved ones, friends weren't there, because ombudsmen and surveyors were not going in, et cetera. So the waiver ended in April 2022, and they gave, in short, CMS gave non-certified aides up to October 6, 2022, to complete training and testing. CMS recognized, as they say, that there was essentially a bottleneck, supposedly, of these TNAs and an inability to get them all trained, et cetera. But so they allowed for the waiver to continue in certain instances. It's not something, again, that we support as resident advocates. It is always important for the CNAs to be supported, both for themselves and for them to have a good and meaningful job and career, and of course, to ensure that residents are safe. And even when doing this, CMS recognized that this policy resulted in some poor care for residents, even though the requirements, again, bullet 2, they did not waive any of the requirements for skills, knowledge, or competency. In fact, this did put residents at risk. So this is very much, in short, we and the Center for Medicare Advocacy and the Consumer Voice both have done a lot of advocacy on this over the past 2 years and have materials on our websites. But I wanted to at least mention that we do have these TNAs out there. We don't know how many they are. We asked at the very beginning when CMS announced this, whether they would require facilities to be reporting the use of TNAs, and CMS refused, and we were very disappointed by that. So we really don't have a good idea of how many are out there. But again, I think the most important takeaway is that the CMS did not waive any of the requirements, and you're still entitled to have the good care, the competency, et cetera. That was not waived, and that did not go away. A little bit more about how we are supposed to be ensuring that nurse aides are competent, that these requirements for curriculum, et cetera, are really integrated into the work of the nurse aides and into the lives of residents in the facility, is that one, we have a requirement under the federal rules for regular in-service training. Again, this is federal, so it applies to every single CNA and every single licensed nursing home. The facility must complete a performance review of every nurse aide at least once every 12 months and must provide regular in-service education based on the outcomes of those reviews. In-service training must comply with the following requirements, as I know here in number 2. It must be sufficient to ensure the continuing competency of nurse aides, no less than 12 hours per year. So every aide has to have at least 12 hours of in-service training per year. It must include dementia management training and resident abuse prevention training. It must address any areas of weakness as determined in the nurse aide's performance review and, again, in that facility assessment. So the facility is required to be evaluating the performance of the individual nurse aides, but also to be doing a facility assessment on an ongoing basis to see where there are special needs, where there are needs that aren't being met of their residents, and to address them. And then for nurse aides that are providing services to residents with cognitive impairments, it also must address the care of the cognitively impaired. So next couple of slides, I want to talk about some considerations for us for resident-centered care. And the question here on this slide is, does the nursing home have enough staff on the floor to meet residents' needs in a timely manner? Some things to think about are residents waking up and going to bed at a time of their choosing, not at a set time? Are residents getting bathed and showered at a time and frequency of their choosing? That's something that unfortunately we saw was seriously exacerbated during the COVID pandemic and continues to be so. I hear over and over again of just honestly heartbreaking and horrifying stories of residents not getting bathed for days, sometimes even weeks on end. Just outrageously inhumane and undignified treatment. Other considerations, are resident call bells being responded to in a timely fashion? If I walk into a nursing home and I see lights or bells going off, that is a red flag to me. What is going on here? Why aren't those being responded to in a timely fashion? And as I'm sure many of you know, so many other things can happen as a result of call bells not being responded to in timely fashion. Someone needs to go to the bathroom. They don't get help in time. They try to get up themselves and they fall and they injure themselves. Or they have to go to the bathroom in their bed, and then they wind up sitting in urine or feces. Horrible and dangerous for them clinically. Lastly, residents not being put in diapers because there are not enough staff, to help them to go to the bathroom. Just what I was talking about is that this is the things that, few of the things that I think about first that I wanted to share with you. Some additional considerations for, again, resident-centered care. These are on our fact sheet. This is the fact sheet, resident assessment and care planning, that I have pictured on the side, and it's on the flip side of that fact sheet. But are staff finding and implementing options that most meet the physical and emotional needs of each resident? This is important. This is what the curriculum that I talked about earlier, the federal requirements for what CNAs have to be learning, talks to exactly being the physical and emotional psychosocial needs of each resident. Are the assessment and care planning processes identifying and seeking ways to support residents' individual needs? And are those processes being implemented by care staff across shift? Very important, not just during the day, not Monday through Friday, on weekends, on holidays. Those residents' needs are the same. Whether it's a Christmas Day, New Year's Day, Veterans Day, or Monday. And the facility has a responsibility to ensure those needs are met. And that includes, of course, day and night. Are these processes being, I said that already, being implemented by care staff across shifts? Are staff informing residents and those they designate about the residents' health status and healthcare choices and their ramifications? Again, these are residents, they're adults, they are entitled to make any choice that they want about themselves and their care. And if they designate someone else to help them with that decision or to make that decision for them, a family member, etc., then those rights, in essence, go to that individual working on behalf of the resident. Some additional considerations, and I won't talk about them all here. Does the facility administration and the environment promote actions by staff that maintain or enhance each resident's dignity? And I think this is something that family resident councils, that ombudsmen, others who are working on more systemic advocacy, either within a specific facility or in multiple facilities or community, can really be thinking about. Because the nexus, as I've said a couple of times, and as the rules say all the time, the nexus is with the resident. And really, we always advocate for the resident and the care staff to be at the center of the nursing home. But what we too often see is a top-down environment. And the facility administration is critically important. But they should be clued into the resident and the staff. And this really gets to, what are we seeing happening here? And what are we seeing going on? These are questions that, again, especially if you're organized as a family council or a resident council, could be useful things to think about. So I won't, again, talk about all of them, but one of the ones that we haven't talked about here, and we don't often talk about, but which is important, is the 1, 2, 3, fourth bullet down, is the nursing home actively assisting residents with discharge planning services. For instance, helping to place a resident on a waiting list for community congregate living, arranging intake for home care services for residents returning home. And we have our latest podcast with Lindsay Heckler from the Center for Elder Law and Justice, and of course, our podcast host, Eric Goldwine. It was really interesting. I listened to it the other day. I was at the gym and I put it on, and they talk about discharge and appropriate discharge and inappropriate discharge. It's a really big issue. But again, these are on our fact sheets, and a copy of this will be available on our website. I just want to note, as I said at the beginning, I would do that there's no excuse for low staffing or poor care, and this is something that is so important for us all to be aware of and to be, in essence, speaking truth to power. I mean, the nursing home industry is extremely wealthy, extremely powerful. They have major lobby associations, law firms that are just focused on supporting that lobbying. And it's really important. Residents don't have lobbyists, unfortunately. And so it's really important for all of us who support these issues to be speaking out with our state and federal legislators, and speaking out to our governor and to the White House, and supporting the president's proposals for nursing home reform. But most importantly, I think underlying that is that we must reject the nursing home industry's myths that they can't do better. And I'm going to talk about two major ones as I identify them. One is that nursing homes do not get paid enough, to provide good care. That's myth number one. And the reality is that most nursing homes are run for profit and are seen as attractive investments. And the nursing home industry is increasingly run by very sophisticated entities, both for-profit and not-for-profit, that are measuring costs, measuring profits or surpluses, and are tuned into everything when it comes to saving money and maximizing the quote-unquote efficiency of their operations. So it's really important to shed some light here and be able to speak at least a little bit to this, and hopefully spread the word on this, is that in fact there is no independent substantiated data that supports the industry's argument that they don't get enough money. And to me, it just seems, frankly, I know I'm an advocate, but it seems kind of bizarre. I mean, you have these very sophisticated private equity firms, real estate investment trusts, other big investors that are buying into the nursing home sector all the time. Why would they be doing that if there wasn't big profits? Your nursing homes continue to say, oh, well, they're losing money on staff. There's a gap between what they're getting and what it costs. They have razor thin margins. But how could that make any sense to anybody if you have these companies that are coming in and are obviously making lots and lots of money? I would also say for anyone, you could see it on our website, or if you go to the New York State Attorney General, the Medicaid Fraud Control Unit of the New York State Attorney General's office has 3 lawsuits that they have filed complaints for. And those lawsuits, they're very long, and we're putting together we have some materials on it, and we're putting together more materials on it. And our next webinar will be someone from that office, but they talk about how these nursing home owners, big owners in the state, took profits, tens of millions of dollars in profits off the cuff, right off the top, and before they even thought about putting money into care. And even one of them complains that even in the face of the COVID pandemic, when the state agency, the State Department of Health, told nursing homes, you need to increase your staffing, this nursing home, they have the emails showing that they said, cut staffing and save over $1 million. We want you, the administrators, save over $1 million in staffing costs in the face of COVID. What does that say about what is going on in these nursing homes? We need more accountability. We need more transparency for where the money is going. And myth number 2 regards to finding the staff. And this is something I celebrated my 20th anniversary with the coalition in November of last year. But I remember reading over the years congressional testimony from the early 80s and even from before that, had the same old story, the nursing home industry representatives saying, oh, we just can't hire enough staff. And the fact of the matter is, and now we have data, and we actually publish these data on our website showing that nursing homes have incredibly high turnover rates. On average, the turnover rate for nursing staff, is 50% a year. Many, many nursing homes have 100% or more turnover of RNs, LPNs, and especially of CNAs. The CNA job is persistently, if you look at the Department of Labor, one of statistics, one of the most dangerous in the United States. And it's really the result of the industry's own practices that they keep staffing down to the minimum possible, endangering their residents, endangering their staff. Working as a CNA can be a degrading experience. It's extremely poorly paid. Is it any wonder that they don't retain staff? And whose fault is it when they don't? It's, of course, their fault. This is a self-fulfilling prophecy. And then to turn around and say, oh, our hands are tied, that's not the case. Every day they're putting into place, not every nursing home, but too many nursing homes are putting into place processes, systems, payment mechanisms that make it impossible for the CNAs to do their job and to stay at their job. And then, so that's really it for the program. I just want to talk about a few of our resources before we leave some time for Q&A. This is our website, nursinghome411.org. Everything on the website is free to use, print out, and share. This is our learning center where you could find our webinars, fact sheets, resources for family and ombudsman, our dementia care and antipsychotic drugging toolkit, information on abuse and neglect and podcasts. And again, you could see this is the learning center. If you can see my cursor right here at the top or over here to access the learning center. And then here's just our page with fact sheets. So you could scroll down. You could see again, if you're having an issue in your nursing home, or if you're helping someone who has an issue with dementia care issue, with the use of a bed rail, antipsychotic drugging, or regarding the family or resident council, et cetera, you can go here and you could find some of the important residents' rights to support advocacy in that area. We have state pages. This is the map of the US, of course. You click on the state and you can find information on nursing home ratings, staffing levels, ombudsman resources, and much more. We have staffing data that's updated on a quarterly basis for every nursing home in the country that is in compliance with the federal requirements for reporting. So you can see nursing homes in individual states. You can see how they compare to other nursing homes in your city or in your county, et cetera. We have resources for family councils, including a free family council Zoom room that you can reserve here by going to families@ltccc.org to sign up for a free meeting room, or go to our website or get in touch with our family council liaison, again, at families@ltccc.org. These are some tools that we have. You can click on, of course, here are our prior webinars. This one will be posted, I think, by the end of the week. And then our podcasts, which I mentioned before, are really interesting. So again, visit us, nursinghome411.org, or you can sign up for alerts to get our forthcoming report and to hear about future webinars, et cetera, nursinghome411.org/join. Our next webinar, as I mentioned before, we're going to have people from the New York State Medicaid Fraud Control Unit, part of the Attorney General's office. They're going to talk about those cases that I mentioned that are really extraordinary, that they have with a specificity that I've never seen in my career. They talk about how these providers, and they document how these providers have put their residents, put their profits above their residents' safety and dignity and well-being, and the safety and dignity and well-being of their staff time and time again. it is really quite striking. I'm looking forward to them talking about it. I should mention that every single state in the country has a Medicaid fraud control unit. So these kinds of cases can be undertaken in every state. So next month's program, should be very interesting. One, to learn about what is actually going on with nursing home profits and costs and nursing home decision-making, and why care too often is so poor, but also because this can support our advocacy in every single state to urge our state attorney general or the Medicaid fraud control unit to go after these providers that put profits before residents in a deadly fashion. And that's it. That's we're going to call it some other links to our website for materials from today's webinar, for our new report just issued in December, A Decade of Drugging, which has some good information as well as data on a really serious issue, one of the most serious issues, I should say, facing nursing home residents in our country, inappropriate antipsychotic and psychotropic drugging, and then to register for our next webinar. And with that, I'm going to open it up for questions and comments, please. And I noticed that some people raised their hands, but I'm going to ask you to please, if you have a question, put it in the Q&A rather than raising your hand, because that's where we're going to take the questions from.
Thanks, Richard. Do you want me to relay them to you, or do you want?
That'd be great. Yeah, I'm sorry.
Okay.
I didn't.
Okay, that's great.
We neglected to talk about that earlier.
Okay. All right. I'm going to start with from. That's not much of a question. From Mary, we don't have access to employee records other than witnessing the lack of training or being told verbally the staff person doesn't have the required training. What do you suggest we do to question the training? Do we submit observations or secondhand verbal knowledge to the state survey authority?
Well, I guess just like with any other advocacy, I would start with the idea of trying to be as constructive as possible, and also starting at the lowest level, and so to speak, and working your way up. So rather than taking it right, unless it's of course, if it's a really emergency situation, then one, you want to make sure that the resident is safe and that residents are safe. And if residents are endangered, you would want to contact the state agency and let them know this is resident endangerment or immediate jeopardy, if that is the case, or even call law enforcement. Or you can call, as I mentioned before, the Medicaid fraud control unit. Every Medicaid fraud control unit takes complaints about resident abuse and neglect. But I would say if it's something that is not an emergency level, I would first raise it with staff, or I would raise it with the facility, and say that, look, it seems like this is not going on. Maybe the residents with dementia are not being spoken to and treated in a way that is respectful and that is understanding of potential reasons for, say, so-called behaviors. Then you could use some of the materials we talked about today, the curriculum, the requirement for in-service training, and as well as the requirements for dementia training, for dementia services and training to support your advocacy there. And if that doesn't work, again, I would take that up to maybe to the administration. I would, if there's a family or resident council, I would try to engage the family or resident council to take on this issue as a group with the administration. And if that doesn't work, or well, I shouldn't say that. In any case, you could always bring in your long-term care ombudsman, and they could be helpful in navigating that. And if those things don't work, is at what point, again, if it's not an emergency, that I would first, take it up and say, look, to the state agency, that the staff in the nursing home are not trained on basic, resident needs as required by the federal government.
Great.
Thanks.
All right. This is from Serge. How can we ensure the review of training at nursing homes is being completed?
That's a good question. As always from Serge. Hi, Serge. I mean, I guess you can ask. I mean, and that would be the first thing. I mean, you know that there's a 12-hour training is required. There has to be training on dementia care. I would ask. I would try to again work through the family or the resident council if there is one. If there's not, maybe forming a resident or family council. That could be something really powerful. As I said, we have a family council liaison who can, two of them actually, who can help you with that. The ombudsman could help you with that as well. And I think that, the more support you show, in terms of families are concerned about this or residents are concerned about that, the more likely you are to get an answer. And again, the question would be, how are you fulfilling, this 12-hour training? What is going on? Maybe as a family council, asking, is there any way we could provide input into the training, or to you about issues that we are seeing cropping up in the nursing home that we feel are not being addressed. So I hope that's helpful.
Great. Okay, so I really like this question from Lori Kraft. Timely fashion is a pretty vague term. How can we make this specific when talking to facility staff?
Well, I'm not sure what timely fashion is referring to. I mean, all the things.
So there's like timely manner. For example, responses to. I believe this is referring to responses to call bells. And things like that, I believe.
Sure. Well, I mean, what is it timely? Timely is in the time that is necessary for the resident to get the help that they need. So if a resident needs help going to the bathroom, then that help should be there within a few minutes, and to take them to the bathroom before they have an accident, before they need to be put into a diaper, and before they're very uncomfortable. I mean, that hopefully should be happening. Now, there are things that staff can do. For instance, we hear a lot of issues with this with residents with dementia. And one way, and again, I'm not a clinician, but one thing that I know has worked very successfully with residents with dementia is to get them on a schedule. So if you're taking someone to the bathroom, say every 2 hours, then you're likely to avoid on a 2 hours. I'm just making this up, whatever the schedule might be, has to be, of course, appropriate for the resident. But say you're taking every 2 hours, whether they need to or not, then they get into the habit of going there. And then there's less likelihood that they're going to have to go in between. And if they do need to go in between, then that schedule may need to be changed or adjusted. But that's a way of avoiding those emergency situations where, maybe someone with dementia doesn't realize they have to go to the bathroom until they have to go immediately. And then it's really hard to get someone there. Doesn't entirely answer your question, but I would say, again, like everything else from the very beginning that we talked about here, and I think in all of our programs, is that it has to be resident-centered. And it shouldn't be that residents are in pain. It should never be that call bells are being turned off and or a staff person saying, I don't have time for this right now. We have other people. That is unfair, obviously, to the resident. It's also unfair to the care staff. Not in the same way, not to the same degree, but it makes, as I was talking about through this whole program, it makes giving good care an impossibility in that situation. And that's maybe a situation that needs to be escalated to the ombudsman, to the Department of Health in the state, certainly to the administration, et cetera. So it is a fuzzy, timely manner is fuzzy, but it really is focused on the resident. I mean, this is not a warehouse. It's not a, it's not you're watering plants, once a day or whatever, or weeding once a week. It is that you accepted residents who have individual needs and meeting those individual needs.
Great. So we're at 2:01, but we started a couple minutes late. So I say we go till 2:05. What do you think?
Okay, that's fine.
All right. So we got a lot of questions, but we'll do 2 or 3 more. From Joan Burke, would it be helpful for residents and family members to view posting by the facilities each month the type of training that's being focused on during that month?
I think it's a wonderful idea. And that's something that, again, a family, a resident, an ombudsman, family resident council certainly can ask about and ask for, not ask about, but ask for. I think that's a really great idea. Thanks, John.
Great. From Mark, are facility assessments discoverable by the public, and how would one go about obtaining?
They're not. They're supposed to be internal, and they are internal, I should say. I believe that they're reviewable by the state survey agency, by surveyors, but not open. And that's because they want facilities to be doing, as honest an assessment as possible, and to be acting accordingly. So I certainly see the strengths in, or the positive aspects, I should say, in making those available to the public, because then we'd be able to see. But again, also the benefits of having it be private, so to speak, because then hopefully facilities will will identify and act on the problems that they have.
Great. We're going to do two more. The first is from Robert Roseth. I take what you say about the role of private equity and other for-profit companies in the nursing home industry, but here in Washington State, we've seen the closure of many nursing homes. Is the industry bifurcated so that some are going out of business and others have large profits? What's going on? The shortage of nursing home beds is causing problems with hospitals that are over their maximum capacities.
Well, that's a really great question. And I think that gets at, what I was saying before when I was talking about myth number one, is that we just don't have the transparency. We don't have the accountability. And one thing, we don't have a lot of time, but one thing that I have seen in recent years that I didn't realize before is that there are ownership groups that are just kind of picking like jackals, picking at nursing homes until there's really nothing left. And we have seen that, unfortunately, mostly with for-profit, but to some extent with not-for-profit too. And sure, in my experience, I always was familiar with nursing home operators who tended to run poorly performing facilities, as we say. But it wasn't until a few years ago that I saw that there were operators and business models that were really looking to just pull out all the resources they could, and then essentially leave a nursing home, a carcass that was not able to function in the long term. And I think some of this, the reasons why we talk about pushback and some of the things that we're thinking about is to try to change the tide and to make it an industry that's less prone to, as that quote I mentioned earlier, less prone to predation, the predatory behavior. And I think, unfortunately, that's true again for profit and not for profit. So how do we change that? How do we move that so that we have a robust industry, but one that is not just being, run into the ground too often by providers?
Great. And we'll do one last question and answer. We didn't get a chance to get to everybody, but we really appreciate your comments and your questions and your participation. This is from Trudy. Can certifications for CNAs be verified via the Office of the Professions in each state?
That is a good question. To be honest, I don't know. I don't think so, but I don't know. I think that the list for RNs, I think that there are lists for professionals, but I don't think that there are for CNAs. There are lists that the industry can use for CNAs, and I believe that more relates to. I shouldn't say that. I'll hold back. I don't think that there are public lists, but to be honest, I don't know that for sure. But anyone, again, who works in a nursing home is required to be a CNA, with a CNA within 4 months now. There are those waivers, which we're very concerned. Hopefully, we'll continue to tighten that up and get rid of those waivers. And most importantly, as I mentioned a couple of times when talking about that slide, everyone who has contact with the resident must have those competencies. Must. That's always been the requirement. There's absolutely no excuse for not having that.
Great. And there's a few people in the comments mentioned that there's There are, you can locate CNA certifications in many states, yeah, and sorry, it's scrolling as I'm talking, so it's hard for me to get this. In California, you can search for CNA certification online via CDPH, so there's different ways to find that in each state. But I think that's it for the Q&A. Richard, anything else you want to add?
No, I don't think so. Yeah, thanks everyone for joining us today. Appreciate it. Sorry we didn't get to everyone's questions. And please join us next month. I'm really excited. I think it will be really interesting. They just did some remarkable work at the Attorney General's office, and we'd like to see that. We'd like to learn about it and to see that expanded into or replicated in other states. But I wish you all a good afternoon. And thanks, Eric and Haley. Appreciate it.